Anesthesiology, a unique and important role within the medical profession that requires intense physical and technical ability, patience as well as compassion. Now, anesthesiologists from across Europe and around the world are coming together in Vienna, Austria. With a rich history in music, art and psychology, this week the city will host the very latest findings and expertise in education and innovation across anesthesia, intensive care, pain, patient safety and perioperative medicine. With attendees coming together to save and improve the lives of patients everywhere, we're here for Euroanaesthesia 2019. This is Euroanaesthesia TV. Welcome back to Euroanaesthesia 2019, the essential annual congress for anesthesiologists from all over the world. It's our third show here at the conference, and we've got plenty of cutting-edge research and on-site reports from across the meeting's diverse and exciting range of activities. We'll be hearing from some of the best abstract prize competition finalists and stopping by the thoracic anaesthesia workshop. We'll also be taking a critical look at guidelines in our main interview of the day as we ask how their reliability can be ensured. Make sure to catch it all.
This is dogma-driven medicine across our field that has to be changed into evidence-based medicine. So it's a mind change, and it's also going away from the culture of publish or perish.
So I will be proposing that we should make these changes now, because cancer is an incredibly common disease. It's getting commoner. And even if the changes we make a tiny difference, isn't that worth it?
Identifying if biomarkers of neuronal damage will tell us those patients who are at risk and enable us to intervene to prevent the short and long-term cognitive consequences.
Next up in the studio, I'll be talking to Professor Lise Everett as we discuss the effect of anaesthesia on the brain in older patients. But first, let's take a look at what's happening in this morning's thoracic anaesthesia workshop.
Thoracic anesthesia is a subspecialty of anesthesia that deal mainly with procedures that involve the thoracic cavity. Some of them are taking part of the lung out, like pneumonectomy or lobectomy. Some of them dealing with the airway of the trachea. Thoracic anesthesia developed as a very defined subspecialty that is practiced by anesthesiologists who really have the training to administer thoracic anesthesia safely and keep up with the latest development in thoracic anesthesia.
During the education of trainees, let's say residents in anesthesiology, they have to have some kind of training also in thoracic anesthesia, but the thoracic is so complex that they need to have a special training in different devices, different procedures. They are very challenging, and this is the reason why we offered the workshops.
The attendees of this workshop here are rotating through different stations, and we have different devices such as different double lumen tubes, different type of endobronchial blocker. We have epidurals for pain, for postoperative pain, different type of blocks that we use. And all these devices, not all the attendees are familiar with them in their hospitals. So they come here, they practice to see one, they do one themselves, and they can go to their institution and teach one.
We have new catheters for pain therapy, for example. We have new devices for ultrasound. We have new devices for lung separation, which are very important in this area here. And you have new devices for visualization of the airways, so that you have the control how good and how efficient is your lung separation. So this is changing permanently. We have every year a new equipment, a new device. It's important to stay updated, and this is one of the reasons why we offer the workshops.
Surgery would be unimaginable without it, but recent studies have revealed that anaesthesia can have a longer lasting effect on the brain, something which may be more pronounced in older people. I'm here with Professor Lise Everett to discuss how damaging that might actually be and what we can do about it. Professor Everett, what kind of effects are you actually seeing?
So we see up to 50% of patients experience postoperative delirium in the short term following anaesthesia and surgery. Delirium is an acute confusional state. It can be hypoactive, where patients are very quiet, don't necessarily follow instructions, and are often confused and having hallucinations but don't talk about it unless they're asked. Some patients have hyperactive delirium where they're very agitated and distressed, and that's obviously much more easily identifiable. Both of those are associated with very poor long-term outcomes, increased mortality, much more likelihood of ending up institutionalised. The other thing that we see is in the longer term, out to 3 months and 12 months, are patients having just subtle sorts of changes in their cognitive function that impact on their daily living. So although the effects are subtle in terms of their ability to do neuropsychological tests, they subjectively feel like they're not functioning the same as they were preoperatively.
It's clear that these effects are more pronounced in older patients. Are they happening in patients of all ages?
Although in our research, we study older patients because the incidence is higher, so our ability to look at associations is more powerful in that group. These problems are happening in younger patients as well, but much less frequently.
Are there any particular types of surgery that bring this about? Types of anaesthesia, lengths of surgery?
So with postoperative delirium, that is associated with increased risk, with increased duration of surgery, and with surgery that is much more invasive. So for cardiac surgery, patients are much more likely to have delirium than patients having a hip replacement. But with postoperative neurocognitive disorders, we don't see an association.
Are there any biomarkers that could identify patients who are at risk preoperatively?
So we're doing a lot of work with biomarkers, both inflammatory biomarkers and some biomarkers that have recently been identified in sports people as identifying neuronal damage similar to what you would see with an acute traumatic brain injury. And our preliminary research, which was published last year in JAMA Neurology, suggests that we do see an increase in those biomarkers associated with anaesthesia and surgery. So the focus of our work at the moment is continuing that research, looking at the cognitive outcomes of those patients and identifying if biomarkers of neuronal damage will tell us preoperatively those patients who are at risk and enable us to intervene to prevent the short and long-term cognitive consequences.
Fascinating. Thank you so much for joining me, Professor Everard.
Thank you very much for your time.
Research in recent years has suggested that anaesthesia may play some role in preventing the recurrence of cancer, but the jury's still very much out on whether that is in fact the case. To find out what this means for anaesthesiologists, I'm here with Dr. William Harrop Griffiths. What is the evidence that avoiding specific anaesthetics during surgery prevents the recurrence of cancer?
Do you know, we've got some evidence that avoidance of inhalational agents, avoidance of opiates and morphine-like drugs has an impact on the recurrence of cancer after primary cancer surgery. The evidence is not convincing. So the evidence comes from large-scale retrospective studies and comes from animal work and preliminary prospective work in humans. What we long for is the result of randomized controlled trials put together in a meta-analysis. The real question is, do we need to be at the top of that evidence pyramid in order to make a change to what we as anaesthetists do every day?
Are you proposing that any changes are made now? And if so, what?
What I'm talking about is everybody's different. Everybody makes a change at different times. You have to be prepared to make a change in your practice to make a change. So some people will wait until the randomized controlled trials have been published before making that change. Some will wait even longer until there's mandatory national guidance that you have to avoid these drugs in certain patients. Some people like me who love change will make a change earlier. But this is the most important thing. The changes that you would need to make to your technique to conform with what we believe to be true about cancer recurrence cost pence and are safe. So I will be proposing that we should make these changes now because cancer is an incredibly common disease. It's getting commoner. And even if the changes we make a tiny difference, isn't that worth it?
You've said that specific anaesthetics are problematic. Which ones are those?
The evidence that we have suggests that all the inhalational agents may impact adversely on your own immune system, and also that opiates have that impact as well. But there's another factor. It seems that the stress response to surgery also has an adverse impact on your immune function. So the regional anesthesia, for instance, in itself doesn't prevent cancer recurrence, but by using it, you A, minimize the stress response, and B, you decrease the need for opiates. Propofol, which is the other drug that's been used in some retrospective studies, is being used in some prospective studies. It's not that drug itself, it's the avoidance of the inhalational agents that make propofol probably, possibly, maybe, perhaps an effective agent in preventing cancer recurrence after surgery.
What might be the benefits of making the change?
You may benefit 1 in 10 patients, 1 in 20 patients, 1 in 50 patients, 1 in 100 patients, 1 in 1,000 patients. We don't know. But even if it's only 1 in 1,000 patients, it may be worthwhile. And the difference you would make that in that 1 in 1,000 patients, their cancer would not come back. I'd take that 1 in 1,000 chance because there's no evidence that using propofol, that using regional anesthesia has significant adverse effects. So possible small benefit, no downside, I'm there.
What hurdles would the change involve?
There are no regulatory hurdles at all. These are techniques that many anaesthetists use in their daily practice. There are people like me who adore regional anesthesia and never happier than when we've got a syringe full of bupivacaine with a needle on it, poking it into a patient. So it's about mindset. It's like doing anything complex in life. You have a way that you do it, a way that you like doing it, a way that you've taught yourself to do. It works well for you. And if somebody then turns around and says, you should change, it's only human nature to resist.
Dr. Harriet Griffiths, that was fascinating. Thank you so much for joining me.
Thank you.
Coming up next, we'll be taking a critical look at guidelines as we assess how much we can really rely on them. But first, let's head out of Vienna to Germany to take a look at the work of University Hospital Erlangen. The team there are working hard to improve the lives of patients through everything from research into pain mechanisms to a state-of-the-art plane for emergency patients.
Anesthesiology is a wonderful medical discipline that opens contact to nearly every other field in medicine. The University Hospital Erlangen is one of the largest university hospitals in Germany. As anesthesiologists, we provide care for the smallest babies to very complex operations in elderly patients, trauma care, whatever you can think about. What makes it special is the spirit of this place, devotion for the best patient care you can think about. Secondly, to generate innovation in medicine, and research can be produced on a broad basis. There are not so many places on the world that offer this diversity.
At present, clinical research of our department is focused on clinical trials in volunteers and patients with a new drug, benzodiazepine remimazolam. This drug produces deep stages of sedation with fast onset and recovery. In these clinical trials, we investigate remimazolam-induced electroencephalographic changes and develop pharmacokinetic and pharmacodynamic models for drug dosage and effect prediction.
For the pharmacokinetic analysis, we determine the plasma concentration of the drug from frequently drawn blood samples, and using these data, we can then develop so-called pharmacokinetic models to describe the elimination and the distribution of the drug. And having these pharmacokinetic model, we can then optimize drug dosing in that way that we can rapidly achieve and maintain the effective concentration, but without overshooting or underdosing.
I'm involved in pain research in a field that is called cold allodynia and cold hypersensitivity, and we are looking at different parts of the body. For example, we are looking at tooth pain and how cold hypersensitivity in teeth emerges, and we're looking at ion channels, for example, that are involved in the process and that would be suitable for potential pain treatments. But we're also looking at cold allodynia in the context of neuropathic pain, and we are looking at models there and at ion channels there and then differences between the both forms of hypersensitivity, so that we can derive potential targets for treatments in both cases.
Our team has to improve the life quality of our patients. We can offer an interdisciplinary multimodal pain therapy here in our pain center. We are all collaborating in the assessment and treatment of patients with chronic pain. It's based on the biopsychosocial program model of chronic diseases.
We treat patients with postoperative pain after big surgery, and we also treat pain within cancer disease and use a lot of different methods like PCA or other forms of regional anesthesia to offer best clinical patient care.
Long-distance inter-hospital transfers of patients on ambulance planes require a lot of medical and logistical preparation, but still in many cases the challenges cannot always be predicted. Some critically ill patients, for instance suffering ARDS in countries abroad, have no possibility to be treated under the same standards as in their home country. In cases like these, we send a team with an anesthetist and a cardiotechnician and a cardiosurgeon to the patient to establish an extracorporeal membrane oxygenation to secure a stable condition in which the patient is able to be transported back home.
The Department of Anesthesiology at the University Hospital Erlangen is committed to excellence in medical education for both the next generation of our medical students as well as for our own staff members. We try to blend current educational theory, the core syllabus for anesthesia and emergency care, and of course our own clinical experience into what we believe are fantastic learning opportunities for our students. The Simulation and Training Center provides state-of-the-art training opportunities. A wide range of simulation equipment make our center a great place to train because they allow us to take learning objectives and select the appropriate simulator to tailor the task to the needs.
It's always exciting in this department. After being around for nearly 40 years in anesthesiology, still there are discoveries which enhance the safety of our patients. Every new day in this field is wonderful.
Great work there from the team at University Hospital Erlangen. Of course, that's just one of our featured hospitals. Make sure to check out some of the others online.
London is a great place to live and work because it's such a diverse place.
I arrived here in London, Ontario about 3 years ago, and I found it for me the ideal place to be.
We send a team with an anesthetist and a cardiotechnician to the patient to secure a stable condition in which the patient is able to be transported back home.
We provide regional anesthesia, neuroaxial regional anesthesia. We have also limbs blocks. So we are probably the leading hospital for regional anesthesia on a national level.
It is still very important to improve the care of our critically ill patients because today still too many patients die to their critical illness. We want to bring innovation and quality improvements to our patients to bring more patients back to life.
The provision of guidelines is a central part of the role that organisations like ESA play in the medical community, analysing the evidence and making recommendations for best practice. However, in a profession where split-second decisions can result in life or death, how much can we trust that evidence? How good can guidelines really be? To discuss this, I sat down with the current and former chairs of the ESA Guidelines Committee. Thank you for joining me, professors. Why are we having this debate about the guidelines? What exactly needs debating?
Well, I think it all comes down to not really the question of whether or not we should have guidelines. It's a question of which format and whether or not we actually want to implement the classical way of looking at it, or we want to have really high standards for how we write and implement guidelines. It all comes down to whether or not we want to give in to the pressure and write guidelines just for the sake of it, for the publication, or do we really want to change our practice?
Dr. Afshari, what are the negatives in the current situation as you see it?
That the negative aspect is that if the guidelines do not live up to the standards that should be the best standards, they may actually be misleading. So we may actually not only endanger our patients, but we will also misguide our colleagues. Most of it comes down to the fact that we have a lot of literature that is of poor quality. We have many traditions not based on evidence-based medicine. It's a dogma-driven medicine across our field that has to be changed into evidence-based medicine. So it's a mind change, and it's also going away from the culture of publish or perish, the fact that many institutions and academic institutions are driven by publication of academic papers without setting the standards high. One of our major issues has been how do we control the impact of conflict of interest. One of the challenges we have that some of the experts may actually be perceived of having too much conflict of interest. So this is another aspect that we need to control.
Professor De Robertis, you're in the pros corner.
Yep.
So how do you respond to Dr. Afshari's position?
We have roughly 1 million citations every year produced. This means that the literature is increasing with a very fast speed, and for clinicians it's very, very difficult to understand what is happening. And so it's a daily struggle. I mean, what I have to do? I mean, which procedure I have to change? Which drugs I have to use? And we need evidence-based medicine, and the guidelines is a way to offer, if they are well developed, evidence-based medicine. Probably most of the guidelines lack authority and lack also a decision process. And that's why probably also good guidelines that already exist are not followed. Where there is not such strong evidence, then we also have to give some clinical reasoning tool to the clinicians. They should understand why we suggest to use that procedure, we suggest to use that drug. The problem is how the guidelines are developed, I think, and how the recommendations are given. Because if recommendation is based on a very, very high level evidence, and if the benefit for the patient is very high, then that recommendation should be followed blindly, I would say. But we have few guidelines like that, few recommendations like that, because the literature is most of the time is not so strict and so clear in response.
And because of that, then we have conflicting guidelines and conflicting recommendations, and then which one is actually the highest standard?
Can you foresee ways that the production and implementation of ESA guidelines will change in future as a result of this debate?
There's a lot of focus on the implementation, but I see my ambition is actually higher than that. That goes beyond that, because guidelines can actually point out areas of research that we need to focus on. So it's not just a matter of writing documents, it's also how to use these documents to change our practices and our research, because that's the essential pillar for our existence. We're talking about $500 billion a year annually basically being wasted because of erroneous research. So it's a huge problem that we need to address, and that is my reservations about mass producing guidelines. I don't believe in mass production. I believe in higher quality. Less is more, in a sense that I want higher standards for our guidelines, and less guidelines, or smaller, more focused guidelines.
Fascinating. Professor De Robertis, Dr. Afshari, thank you so much for joining me.
Thank you to you.
Thank you. It was a pleasure being here.
Plenty to think about there, and hopefully a discussion that will continue to inform the guidelines the ESA provides. Now, to take a look at some of those guidelines, I'm joined by two of this year's guideline authors. Professor Leoni, Professor Lamperti, why are guidelines so needed in your particular field?
In the field of perioperative hypoxemic patients, there is a lot of literature and a lot of new devices emerging, and there is a real need to make a point for the clinician to use the best device for the best patients.
For the purpose of the ultrasound guidelines on perioperative use of ultrasound, the main need from the anesthesiologist is to have a clear idea on when to use and which is the training that is required for the ultrasound.
Professor Lamperti, you've been talking about the use of ultrasound to guide regional block anesthesia and vascular access. What are the main differences in the requirements between the two?
So there are not so many differences, mainly in terms of training. So they are moving from the classical didactical training to what is called now disruptive education. Mainly the trainees will have the possibility to use any kind of media device, and the training will be faster than what we were used to have before.
Professor Leoni, you've placed quite a lot of emphasis on positive pressure ventilation over conventional oxygen therapy. How confident are you in that advice?
We're confident because there is a bunch of literature now, and specifically for the abdominal surgery patients, there is a very good publication from a French group led by Samit Jaber, and this publication clearly shows the benefit to use non-invasive positive pressure ventilation in those patients, in those populations.
Professor Leoni, you've sometimes given weak recommendations on the basis of high quality evidence. Why is this, and how should professionals interpret that in their day-to-day jobs?
Because the analysis of all the randomized clinical trials shows that there is some limitations, and when we were not absolutely confident in the type of randomized clinical trial, in the type of population, we downgrade the level of recommendation.
Which of your guidelines would be hardest to implement, and how confident are you in those guidelines?
The main problem will be related to the training, because it will be very difficult to retrain or to certify all the European anesthesiologists.
Until now, there is a lot of guidelines, but no lot of measurements of guideline implementation. So we need to measure that. We need to assess the level of implementation in each European country.
We've just been talking to the current and former ESA Guidelines Committee chairs. How difficult is it to ensure that your guidelines are trustworthy and reliable?
Whenever the evidence was lacking, as it happens in many of the guidelines, we mainly reach a consensus, and the applicability of this consensus will be under the supervision of each institute, each national entity, and even the governments of the European countries.
We think our guidelines are quite reliable in 2019, okay? Because we screen more than several thousands publications. We select the best level of evidence, and we avoid, if possible, the expert opinion. All in one is quite reliable.
I'm glad you're doing such good work on that. Professor Leoni, Professor Lamperti, thank you so much for joining me.
Thank you.
Now, as our final show draws to a close, it's time to recognise some of Euroanaesthesia's top new researchers. The ESA's Best Abstract Prize competition seeks to recognise some of the most exciting new discoveries in the field. Let's hear from some of this year's finalists.
The ESA Best Abstract Prize competition is dedicated to young researchers in order to give them a chance to present a very high-ranking work. Every year, about 1,500 abstracts are sent to the ESA for Euroanaesthesia, and the 6 best abstracts are selected for the prize.
The focus of my study is to participate of 15D prostaglandin J2 and PPL gamma about the anti-inflammatory effect of dexmedetomidine. The combination of LPS and dexmedetomidine increases 15D prostaglandin J2 via alpha-2 adrenergic receptor, and the increase of PPL gamma with increase 2. One of the possible mechanisms of the anti-inflammatory effect of dexmedetomidine is to increase 15D prostaglandin J2 via alpha-2 adrenergic receptor.
The focus of my study was to evaluate plasmatic concentration of lidocaine and its safety when administered intravenously or by paravertebral route during lung resection surgery. The most interesting finding in my study was that paravertebral infusion of lidocaine has a high systemic absorption, and so patients who receive lidocaine by paravertebral route may present the same beneficial effect as when it is administered intravenously. In addition to that, both perfusion, intravenous and paravertebral, are safe during lung resection surgery.
So the focus of my study was about CO2 removal. We tested a new CO2 removal device called MEMSOR. So we tested this device on 12 patients in vivo during a robot-assisted radical prostatectomy. So we think the MEMSORP is a great example of innovative technology that we need at times now that the environment has become such a hot topic. While using low-flow anesthesia, we can eliminate the use of soda lime canisters, and this way it can lower the burden on the environment of the use of inhaled agent anesthetics.
I've been chairing this abstract competition for several years, and I really do enjoy this moment, this session. For some of them, it's the first time they present in front of such a huge audience. I'm really happy. Maybe that's my favorite session in ESA.
2 years have passed after I started my study. So this nominee leads me to motivation for my study in the future.
It's a great pleasure to be able to present on a congress like this. You put a lot of hard work in these studies, and it's a great stimulus to continue doing scientific research.
Having been nominated is a pleasure for me, and winning would be more than I've ever expected that I could achieve as a second, third year resident of anesthesiology.
It's the end of our final show here in Vienna, but before we go, let's hear from attendees one more time. We wanted to find out what most excites you about coming to Euroanaesthesia every year.
I think it's a place where anesthesiologists all over Europe or over the world can meet, and we can share our experience, and we can improve our knowledge, and we can see new things which comes to our department and to our operating theatre.
This is the third one I've been to, and I've enjoyed the variety of sessions and meeting friends from around the world, so it's a great meeting and I really enjoy it.
Actually, I'm not from Europe, I'm from Asia, I'm from Iraq, but this is the most important event in the anesthesia that's happened yearly, and for me it's the first time to participate, and it's usually worth it.
All the updated information will be here. We get interaction with many delegates from all over the world, which make it wonderful. Otherwise, we feel a little bit away from our group, our fellow anesthetists.
I come to this conference every year, and it's like putting my finger on the pulse of the world of anesthesia.
Well, I'm in the workshops for regional anesthesia, and absolutely, well, honored to be over here. It's a great pleasure, great time, great ambience.
I find Euroanaesthesia a really good one to come in, because usually there's a lot of focus on regional anesthesia, which I'm interested in, and also patient safety aspects. It's just nice to meet, people from different countries and see a bit of culture as well of Europe. So yeah, it's very interesting.
We're glad you're all enjoying Euroanaesthesia 2019. We've had a great time here with plenty of fascinating insights from across the diverse and exciting field and its passionate, engaged community. Remember, whether it's perioperative risk, patient blood management, or simulation training, there's plenty for you to watch on Euroanaesthesia TV. If you've missed anything, make sure to catch up online and share anything you find interesting with colleagues. Enjoy the rest of the meeting. We'll see you in 2020.